Good morning and welcome. I'm happy to bring you this session, The Unique Contributions of MS Nursing. The IOMSN has established a lexicon of new terminology in MS care. Such adherence have become a standard throughout the spectrum of care. Best practices in MS in symptomatic care are accepted worldwide, and published information has provided the next generation of nursing professionals with a reference of material that adds to their body of knowledge in MS. Additionally, the IOMSN has supported all nurses from nursing professionals at entry level to advanced practice. So let's get started. I'd first like to introduce Amy Perrin-Ross. She is a nurse practitioner that practices out of the Loyola University in Chicago, Oak Brook, Illinois.
Welcome, everybody, and thank you so much for joining us for the second of the nursing sessions here at the virtual Actrims meeting. I'm so pleased that you are able to join us this morning. I am Amy Perrin-Ross. I'm an advanced practice nurse at Loyola University Medical Center in the western suburbs of Chicago, and I have been tasked with talking about sustaining adherence in multiple sclerosis. So as we think about it, there are a multitude of factors that contribute to the optimal management of people with MS. And what we want is an optimal overall outcome. And what you can see in this diagram are that, again, there are a multitude of factors. We look at things such as relapses, disability progression, and MRI activity. Certainly those things are of importance to us as clinicians when we're looking at making treatment recommendations for our patients. But we also look at safety and tolerability, and as you can see, certainly adherence is one of the key factors here. We're going to go into a little bit more detail with respect to adherence in just a few minutes. But we also need to remember that adherence to complex protocols in multiple sclerosis is far more than just adherence to medication. You know, many years ago when we first started, the only thing that we were really talking about is adherence to injectable therapies. But it's gone far beyond that now. We need to remember, we need to look at things such as symptom management. We need to look at the quality of life. We need to consider things like cognitive function in our patients, as well as what kind of support services are available for our patients for whatever disease-modifying therapy we might be recommending. So the definition of adherence really is that it's active, voluntary, and collaborative involvement of a patient in a mutually acceptable course of behavior that results in a desired either preventative or therapeutic outcome. That's a pretty big mouthful. I think some key words here are voluntary and collaborative. Gone are the days when we are making decisions for patients and telling them this is what you're going to take, because we all know how well that works out for the most part. And this really has to be a mutually acceptable course of behavior. And I find that one of the challenges when we're looking at adherence, whether that's to disease-modifying therapies or complex protocols involving lab draws, vaccine initiation, any of those kinds of things, is actually an issue that with respect to the patients, we try to look at behaviors and the kinds of behaviors that they undertake every day. So we need to involve people like our primary care partners to be able to look at overall health and well-being for our patients. So some of the core elements of adherence include partnership, as I said, mutually acceptable goals, and a therapeutic alliance. I know when we're seeing patients in our office, very often it's after some sort of a relapse or at the time of diagnosis. And, you find patients will pretty much agree to anything at that point in time. They're scared, they're nervous, they are trying to recover from whatever has just happened to them, and they agree to anything. But then as time wears on and hopefully they recover from their relapse or their initial presenting symptoms, that adherence can easily go out the window if we don't have mutually acceptable courses of behavior. What about adherence specifically in multiple sclerosis? As I mentioned, it's multifactorial. There's more to life with MS than just treatments. And I do talk to my patients about the fact that there's a lot of components that are going to go into helping them manage their life with MS. Now, some of the newer treatment regimes require adherence to lab monitoring, specialist visits, ongoing screening, things like visits on a regular basis with a dermatologist, with a neuro-ophthalmologist, and other colleagues. And again, with my patients, I always stress the importance of, number one, having a primary care practitioner, and number two, seeing them on a regular basis to once again try to help these people live the most healthy life that they possibly can. I tell them that their MS should not define them, and they need to define themselves. Patients and care partners, again, need to understand their roles and responsibilities and what their implications are for adherence. Very often the care partners will accompany these patients to their visits, but they're not so sure necessarily of what their role is or what their role needs to be. So I try to include them in as many of the early discussions as I possibly can. So let's look at adherence from individual risk-benefit preferences and then strategies to optimize specifically disease-modifying therapy adherence. So we have to look at the relative values of preventing future disability versus the fear of side effects. Again, people, if they read a lot of the literature that comes along with or that we offer them with respect to the various different disease-modifying therapies, they're scared off, and they really are not interested in any of those drugs or their side effects. They're scared of cancer. They're scared of infections. Certainly today, in the days of COVID-19, they're concerned about doing anything to their immune system that might put them at risk for COVID. So that's part of our discussion these days, where it wasn't as much as 6 months ago. We need to try to present the data in understandable terms. Talk to them about what a relapse is. Talk to them about what those lesions on their MRIs mean. And we very often will sit with them and review their most recent MRI and show them what we mean by gadolinium-enhancing lesions or T2 lesions and what we mean when we talk about T2 lesion burden. We want to recognize the potential for conflicting information from alternative sources. That great premier medical resource, Dr. Google. Many of our patients come into us with a tremendous amount of misconceptions, and I think you're probably experiencing the same thing. So part of what we need to do is help dispel those misconceptions before we go any further. Recognizing that the patient's tolerance for risk may actually even be greater than what the healthcare provider's tolerance is. So that's where we get into the important discussion of risk versus benefit and how much risk are they willing to take for the benefit and how much risk are we willing to take for the benefit. And it's essential to have a non-judgmental, trusting relationship, even if the treatment decision of a patient sometimes conflicts with our recommendations. And I can think of one patient that I have who told me absolutely at our first discussion that he would not do any injectable therapies. So we spent a long time talking about oral therapies. He and his mom said they needed some time to think about it. They called me back about 2 weeks later and said they had decided on something, and lo and behold, it was an injectable therapy. And I was quite surprised by that. But Mom said, you know, he's only 19 years old. He's never taken a pill in his life. He's going off to college. We don't think he's going to take a pill. So we think that this injectable therapy that can either be given by me, meaning Mom, at home, or the school nurse is an ideal therapy for him. So we changed course, and that's the way we went. Looking at the strategies to optimize disease-modifying therapy adherence, again, the important thing here is the education of our patients and their families, and we need empathetic attention. We want to recognize that there are many different stages of coping and many different ways that people cope with the concept of a chronic illness. We also want to recognize what impacts there are to treatment in terms of people's lifestyle, particularly with respect to side effects, how often they occur, and how they impact the patient's daily activities. And we also want to anticipate that the patients are going to have some doubts if they have breakthrough disease or if they have symptoms that reoccur. In the hot weather that we're experiencing here in North America right now, many of my patients are having all kinds of breakthrough symptoms in terms of heat intolerance, fatigue, difficulty walking, some of those kinds of things. And we're basically talking them off the ledge of quitting their disease-modifying therapy and telling them not that their disease-modifying therapy has failed them, it's that we have symptoms that occur and that will continue to occur. So thinking about some of the considerations for adherence, we try to balance our medical considerations and our patient considerations. We want to talk about the burden of disease that includes the enhancing lesions, the disease course, the number of relapses that they have. And we want to balance that with what the patient's lifestyle is like, what their expectations are, what their capabilities are. Again, the 19-year-old that I was just mentioning, he and his mom recognized he was not capable of remembering to take a pill every day despite reminders set on his cell phone and things of that nature. So we regrouped and went with an injectable therapy for him. Shared decision making. I put this in here now because I think it's absolutely one of the key issues in terms of adherence to these complex protocols. And shared decision making occurs when a healthcare provider and the patient and their care partners work together to make a decision that's best for that individual patient. And the optimal decision actually takes into account not only evidence-based information about the available options, but us as providers, our knowledge and our experience, as well as the patient's values and preferences. And there are really 5 steps to shared decision-making. You can see them here. We want to certainly engage patient participation. In order to engage them, we have to educate them about what these complex protocols are that we're asking them to adhere to. We want to explore and compare treatment options. In our practice, we don't believe that there's any one therapy that's right for all of our patients. So we look at different options for different patients and taking into consideration what the patient's values are and what their preferences are, what they think they could do. We want to reach a decision on treatment with the patient and their care partners, and then help to evaluate that decision. So when looking at, again, promoting adherence to these complex protocols in MS, MS care has evolved to both earlier as well as aggressive types of treatments. And many treatments require not only active patient, but family and care partner participation as well. And we have to look at the extent of both physical as well as cognitive disability challenges when we're considering recommending therapies to our patients. So what do we do to promote adherence? Well, we want to clarify what realistic expectations are. People want a cure. People want to stop this disease dead in their tracks. and I don't blame them. But given the current landscape, that really isn't a realistic expectation. We want to do as much as we possibly can to mitigate the impact of the disease on this patient's life today and for many, many years to come. We want to advocate for our patients, certainly assisting with reimbursement, identifying resources that they have, involving the families, involving our pharmaceutical care partners, because many of them have reimbursement teams, they have nursing education resources that we can refer our patients to. And we want to talk about the critical role of adherence in looking at outcomes. What you don't take isn't going to work, and that's one of the things that I remind my patients of on a regular basis. So I also want to look at recognizing any barriers to adherence and addressing them right up front. And those barriers change over time, particularly if we have young patients who are starting families, who are trying to work. You know, you bring a couple children into the mix and new barriers are put up. So we need to address those as those come about. And certainly, first and foremost in our minds today are looking at the ethnocultural barriers. And being a white female, I may not recognize some of those ethnocultural barriers. So I need to talk to my patients about what those are and what they might be. So what are some of those barriers? Well, communication problems. What I say may not actually be what my patients are hearing. So we need to make sure that we are validating what we're telling our patients. We need to recognize what their knowledge deficits are, what they think they know versus what they really do know. Certainly recognizing any physical impairments, looking at social and cultural variables, as I mentioned, looking at financial concerns. I had a call from a patient this morning who said, I showed up at the infusion center for my infusion today and they couldn't give it to me. I lost my job last week and my insurance is gone. Nobody's going to pay for this. What am I going to do? I'm so scared. Well, we've got to regroup. We've got to look at what therapy might be the best for her in her current situation. We need to look at emotional distress in our patients. And with everything that's going on with COVID these days, so a tremendous amount of emotional stress, not only in our patient population, but in their care partners and in those of us who are trying to manage multiple additional tasks in our day-to-day practice. So if we look at topics in MS treatment, there are current guidelines that are published by the MS Coalition and the Consortium of Multiple Sclerosis Centers that you can see here. And I would highly recommend taking a look at those. They are available on the website for the Consortium of Multiple Sclerosis Centers, and that website is mscare.org. Thinking about the use of disease-modifying therapies in MS, we want to look at starting disease-modifying therapy as soon as possible after a diagnosis. And we want to consider the effectiveness of that therapy, one, if they're actually taking the therapy, and number two, if it's effective or not, because now we have many other options, and we know that one therapy is not right for all of our patients. Some of us look at NEDA, or no evidence of disease activity. That's very difficult to measure outside of a clinical trial. Some of our patients are aware of it. If they are and they bring it up, we certainly do discuss it. This is a list of some of the approved disease-modifying therapies, and I hate to say, but the day that I sent these slides in, it was updated. But since then, it has become outdated because there have been additional therapies that have become available just in the last week. So thinking about initiating treatment for relapsing MS, we want to match the patients with the disease-modifying therapies, and we've talked a lot about the factors to consider. And I venture to say that one of the big issues today is actually access. And that access changes on a daily basis as people are changing jobs, losing jobs, making insurance changes. For those of us in North America, particularly the U.S., that's a challenge. It may not be as big a challenge in some of our other countries, but it certainly is for us. We want to look at the shared decision-making model in selecting an initial disease-modifying therapy and defining what treatment goals are and appropriate expectations. What do we expect from the treatment? What should our patients expect from the treatment? And what's realistic to expect? Again, I always temper that discussion with the issue that these disease-modifying therapies are meant to slow down the progression of disability, to impact MRIs, and to reduce relapses. For the most part, they do not help with symptom management, and so we need to look at other options for symptom management. So we think about safety and efficacy. Well, there's a fair number of serious safety concerns related to our disease-modifying therapies, particularly some of the ones we consider high efficacy therapies. Looking at what are we doing to immune surveillance? What about the risk for malignancies, autoimmunity, teratogenicity, rare but sometimes serious infusion reactions, and certainly, what about the unknown? What about these therapies, perhaps the ones that are newer to the market, that we don't have 20, 25 years of data on? What are those kinds of things going to be moving forward? Well, we can't predict the future, but we have to have those conversations with patients. You can see on the right-hand side of the slide that there are plenty of manageable safety concerns, things that we can do and that nurses are particularly good at in terms of strategizing with each individual patient and helping them recognize what is appropriate for them. Again, we've talked about some of the adherence challenges here. Treatment fatigue, and I see this in our patients who are getting infused and they've been being infused for 3 or 4 or 5 years and they're frankly tired of going to infusion centers. Other patients who are just tired of self-injecting. Other patients who are just over it in terms of taking daily medications, taking pills on a long-term basis. We need to address treatment fatigue and what the impact of that can actually be on adherence. And maybe that's a major reason for considering a switch in a disease-modifying therapy, because we know if they have treatment fatigue, they're not likely to be able to continue with their disease-modifying therapies. A key point for today is actually looking at some of the vaccine recommendations, because this is top of mind with most of our patients today with respect to starting. What should I take? Should I start something or should I wait? Well, we want to look at preventing infections through vaccines. This is a key part of our care for people with MS. And people with MS should receive vaccines according to the standard vaccine guidelines, but before receiving any vaccines, they should talk to their health care provider. And this slide has a lot of information on it, but the second bullet is probably the key, and that is that live and live attenuated vaccines are generally not recommended for people with MS. And I would recommend that if you're facing some of these vaccine discussions with your patients, that you look at the American Academy of Neurology guidelines for vaccines. It was published in late 2019 in the Green Journal Neurology. It's an excellent article, a lot of evidence-based recommendations that you could see here. You're also going to need to take a look at the product information for whatever therapies the patients are actually on, because the recommendations for the timing of vaccines varies with each of the individual therapies. And again, whenever we can, avoiding receiving live vaccines, regardless of what therapy they are on. and stressing the incredible importance of getting an annual flu vaccine. So thinking about making treatment decisions, again, we want to consider the risks and the benefits. One of the things that we hadn't mentioned previously, but that is a big issue for many of our young patients these days, is pregnancy issues. And are they actively planning pregnancy? Are they becoming pregnant and not having planned at all? And where are they with respect to their disease-modifying therapies? In the United States, the FDA has updated some of the PLLR recommendations with respect to pregnancy. The A, B, C, D, X categories have been removed, and much of the recommendations that are listed in the product information is relying not just on animal data as we had previously done, but now much more so related to human data with respect to pregnancy as well as lactation. And finally, then, I will make my pitch for the comprehensive team approach, putting our patient at the center of the care here, not only the patient, but their care partner, remembering to bring in pharmacists who are incredibly helpful for us in terms of additional education for our patients as well as access, remembering things like physical therapists, rehab, occupational therapists to help with the rehab component in terms of symptom management, as well as the primary care physician. So I hope this has been helpful. Remember, adherence to complex protocols in MS is far more than just adherence to disease-modifying therapies. And with that thought in mind, the shared decision-making approach seems to be the best approach to this comprehensive care team approach to patient care. Thank you.
Thank you so much, Amy. It's a great presentation. And so now we'll move on to Stephanie Agrella. She is a nurse practitioner at Central Texas Neurology Consultants here in Texas, United States.
Hi, everyone, and thank you all for joining me today. My name is Stephanie Agrella, and I'm a nurse practitioner practicing just north of Austin at an MS clinic in Round Rock, Texas. I'm pleased to be presenting today as part of the session, Unique Contributions of MS Nursing, and I'll be discussing best practices in MS nursing as it applies to advanced practice. With that in mind, let's review today's session objectives. First, we'll define the advanced practice registered nurse. We'll recognize the types of APRNs and identify their various practice settings. We'll describe the roles of the APRN in optimizing patient care and treatment in MS, and we'll discuss collaborative approaches in MS patient care. Lastly, we'll describe limitations and challenges for APRNs in MS care and discuss methods for addressing these. We'll begin with our first objective, defining the advanced practice registered nurse. So as many of you know, APRNs are registered nurses that have been educated at a master's or postmaster's doctorate level within a specific role and patient population. We've completed advanced education that's both didactic and clinical in nature, and we've obtained expanded and advanced knowledge and skills, which allows us to provide safe, high-quality patient care. APRNs are prepared by both education and specialized certification to practice and provide care to patients within our advanced scope of practice. And scope of practice really refers to the services that APRNs are permitted to undertake in keeping with the terms of their professional license. Broadly speaking, APRNs are prepared to assess, diagnose, and manage patient problems, order and interpret tests, and prescribe medications, practicing within a variety of settings and populations. Next, we'll move on to our second objective. So let's recognize the different types of APRNs and identify their various practice settings. APRNs include nurse midwives, certified registered nurse anesthetists, certified nurse practitioners, and certified nurse specialists. Now let's take a moment to describe each of these important specialists who provide patient-centered care within different settings and environments. We begin with the certified nurse midwife. Nurse midwives are clinicians with advanced education and training, specializing in women's reproductive health and childcare. The certified nurse midwife provides a full range of primary health care services to women throughout the lifespan, including gynecological care, family planning services, preconception care, prenatal and postpartum care, childbirth, and care of the newborn. In addition to attending births, they perform annual exams, give counseling, and of course, write prescriptions. This care is provided in diverse settings, which may include the home, hospital, birthing center, and a variety of other ambulatory type of care settings. They may practice autonomously or in collaboration with a medical doctor, depending on the state within which they practice. Next, let's discuss the certified registered nurse anesthetist. Again, CRNAs have advanced training and certification, which allows them to provide anesthesia and related care before, during, and after surgical, therapeutic, diagnostic, and obstetrical procedures. They're prepared to provide the full spectrum of patients' anesthesia care and anesthesia-related care for individuals across the lifespan whose health status may range from healthy through all recognized levels of acuity, including persons with immediate, severe, or even life-threatening illnesses or injury. They certainly provide pain management and emergency services such as airway management, and this care is, of course, provided in diverse settings, including hospital surgical suites. CRNAs are qualified in some states to practice independently of an anesthesiologist, or they may collaborate with one. The certified nurse specialist is educated at an advanced level to care for patients in one of 6 described populations and across the continuum of care. A CNS's specialty may be defined by the population that they serve, the setting within which they work, a disease or medical subspecialty, the type of care being provided, or the type of problem that is being managed. The role of the CNS encompasses not only the patient, but also the nurse practice, and healthcare organization and system. The CNS is responsible and accountable for diagnosis and treatment of health illness states, disease management, health promotion and prevention of illness, and risk behaviors among individuals, families, groups, and communities. They too may practice autonomously or in collaboration with a medical doctor, depending on the state within which they practice. Nurse practitioners are expert clinicians that provide initial and ongoing comprehensive care. NPs utilize our clinical expertise in assessing, diagnosing, and treating health conditions. We may also perform procedures within our authorized scope of practice. We provide comprehensive care to patients in family practice, pediatrics, internal medicine, geriatrics, and women's health. We are often prepared to practice as primary care NPs, but there are many distinct national competencies and unique certifications for NPs to include the adult NP, the psychiatric NP, family nurse practitioner, and geriatric NP, just to name a few. All NPs place an emphasis on health promotion, disease prevention, health education and counseling, as well as the diagnosis and management of acute and chronic diseases. We too may function autonomously or in collaboration with a medical doctor. So let's look at the numbers of APRNs practicing within the US. We have a little over 11,000 certified nurse midwives, 40,000 certified registered nurse anesthetists, 72,000 clinical nurse specialists, and well over 290,000 certified nurse practitioners. APRNs have been found to improve patient access to healthcare, have consistently been found to provide APRNs improve patient access to healthcare, have consistently been found to provide safe, high-quality patient care while at the same time reducing healthcare costs, and of course are a vital part of the healthcare system in the United States. Looking at the settings within which APRNs practice, we can be found in a variety of them, from private practice, hospital settings, inpatient, outpatient clinics, homes, birthing centers, surgical centers, federally qualified healthcare facilities, VAs, and of course, MS centers of excellence. With that in mind, let's next describe the roles of the advanced practice registered nurse specifically as it applies to optimizing patient care and treatment of MS. When we're talking about advanced practice nurses in MS, we're really referring to specifically certified nurse specialists and certified nurse practitioners. And of course, these APRNs have become a pivotal member of the MS healthcare team. In a chronic disease with a variable course such as MS, patient care, of course, can be complex. And so the specialized knowledge and skills of APNs contribute to structuring management plans that synthesize evidence-based practices and hands-on experience to ensure optimal outcomes for our patients. When evaluating the MS patient satisfaction as it pertains to their care with the MS APRN and MDs within the MS Center, we turn to a recent study by our colleagues, Dr. Smitha Mary Totem and Mary Jean Busey. The purpose of this study was to determine patient satisfaction with physicians and NPs, specifically in an MS center. This was a cross-sectional pilot study involving satisfaction surveys, and results found that patient satisfaction with both types of providers was high. Both providers spent similar amounts of time with their patients, and encounter length was a strong determinant of patient satisfaction. Scores were significantly lower when the duration of their office visit was less than 20 minutes, and satisfaction was higher in patients who were diagnosed with MS for 10 years or more, or had progressive MS, and that was irrespective of provider type. Because of the previous lack of research and data with regards to the advanced practice nurse's role in MS, the International Organization of MS Nurses convened an Advanced Practice Nurse Advisory Consensus meeting to define the MS APN's role. From that meeting, the roles, domains, and competencies of the MS APN were summarized. And if any of you are interested, this monograph can actually be found on the IOMSN website, and the reference is at the bottom of the slide. We also looked to nurse practitioner Dr. Carrie Samarco and colleagues for guidance from the MS Nurse Practitioner's Handbook, because as many of you know, patient care in MS can be multifaceted. Given its variable disease course and chronicity, MS APRNs must have in-depth understanding regarding the pathophysiology of MS. Not only does the MS APRN assess and diagnose new, stable, and acute individuals living with MS, we also order and interpret the appropriate diagnostic tests that are needed to evaluate and diagnose MS, and in many cases, we perform certain procedures such as lumbar punctures. A great majority of the time that we spend providing care to those who are living with that MS has to do with treatment. From DMT selection and monitoring to symptom management, the MS APRN actively and expertly prescribes, and of course, we evaluate and treat the acute issues that those living with MS may experience, such as relapses. Additionally, we recommend and prescribe appropriate interventions, from referrals to specialists and other healthcare providers. We refer to therapists, all of whom assist our patients with maximizing their outcomes. And certainly if needed, we prescribe assistive devices. Along the way, we provide education to our patients, and of course, we are tirelessly working as advocates for our patients as well. Additionally, we have many other roles, and these are actually listed here based on previously published MS APN monograph and other articles on the subject. The roles of the MS APN in the context of their overall goal of maximizing outcomes for patients with MS and their families has been specifically defined. And of course, APNs typically fill several roles within an MS center or clinic, and these roles include the administrator, educator, collaborator, consultant, researcher, and advocate. So let's take a moment to look at each of these roles, beginning with the administrator. As an administrator, the MS APN may be responsible for a variety of administrative duties, including supervision and scheduling of staff, budgets, policy and procedures, and developing protocols and developing the ensuring quality assurance. The MS APRN also has educational responsibilities, including teaching others about MS. Certainly, patients and families are provided with information and education about the implications of an MS diagnosis, the pathophysiology of the disease, prognostic indicators, and pharmacological and non-pharmacological management options. We also educate in an effort to establish realistic expectations as well, highlighting lifestyle and treatment options with patients and families. And we work to instill our knowledge and skills in colleagues so that they too may learn and grow as professionals. The MS APN has become a major force in evidence-based practice by participating in research and clinical trials. As investigators in clinical trials, the MS APN coordinates research efforts, performs physical examinations, ensures patient adherence to protocol, and evaluates outcomes. We are also advocates, and as such, MS APNs have far-reaching responsibilities. Patient advocacy is an important role for the MS APRN and involves negotiating on behalf of patients with employers, insurance companies, and other external agencies in order to ensure the best care possible for our patients. APNs offer emotional support as advocates for nursing and other staff members that we work with as well, and MS APNs monitor outcomes of patient care. We guide staff in skill acquisition. We facilitate interdisciplinary care patterns and act as role models for students and newer members of the MS team as part of our advocacy role. As pivotal members of the MS healthcare team, we collaborate with multiple disciplines through referrals for appropriate care and follow-up. This includes collaborating with neurology, therapists, social and caseworkers, and others. And MS APRNs network with representatives, community support services, and other programs to ensure that patients have full access to appropriate medications, technological aids, and other types of assistance. Let's further discuss collaboration and specifically collaborative approaches in MS patient care, because with a team approach between healthcare professionals, we are all able to facilitate a comprehensive, continuous, and truly unduplicated range of services for patients and families. By working together with neurologists, nurse colleagues, medical specialists, rehab specialists, and a wide array of individuals providing technical expertise and support, we are able to, through collaboration, facilitate appropriate interventions for patients' needs in disease management, disease state monitoring, rehabilitation, and psychosocial concerns. With collaborative care, we not only expand access and reduce healthcare expenditures, we also ultimately improve the quality of healthcare that's provided. Research has demonstrated that practices that utilize interprofessional teams of advanced practice NMDs demonstrate lower labor costs, increased access, and increased job satisfaction. Studies have also found that patients don't distinguish differences in care by provider type, and importantly, they are satisfied with their care. Additionally, research has found that we improve access when we utilize collaborative care, meaning that more patients can receive quality care if organizations utilize their workforce resources effectively. So let's move on to our fifth objective and review some of the challenges for APRNs in MS care and discuss potential methods for addressing them. A variety of historical regulatory and policy barriers have limited the APRN's ability to contribute to widespread transformation, and various laws from state to state on scope of practice has also contributed to practice barriers. Additionally, varying institutional regulations on scope of practice may also act as a challenge for APRNs. We also see that there can sometimes be a lack of understanding of the APRN's role, which can contribute to barriers. This may be by institutional administration, physicians, other healthcare personnel, and even patients. Other challenges may include reimbursement, perhaps related to outdated insurance policies or due to a fragmentation of the healthcare system. Professional resistance to expanded roles of APRNs may also serve as a challenge, as may resistance from patients, and a lack of formal specialty training in neurology and MS neuroimmunology may also be a challenge for some APRNs. With that in mind, my colleague Brian Walker and I posed a question in a 2016 survey regarding perceived challenges to advanced practice providers when first starting out in the practice of MS specialty. And our results found that the lack of formal education in MS diagnosis and treatment was one perceived challenge, as was the lack of formal education in neurology. State restrictions on practice was also identified as a challenge, as was institutional restriction on practice, lack of patient understanding of the advanced practice provider's role, and lack of other providers' understanding of their role as well. So how do we address these challenges, whether real or perceived? Well, we must find creative ways to overcome these barriers. This may include policy statements directed towards states and institutions, the assistance of goodwill ambassadors or champions like our physician colleagues. Educational outreach to patients may also assist, and educational initiatives directed to advanced practice in MS care may assist with increasing knowledge and reducing barriers. Lastly, educating healthcare providers and professionals about the role of APRNs through educational programs such as this one and others can help to increase knowledge about the roles and benefits of APRNs in providing care to patients who are living with MS. In summary, APRNs are healthcare professionals nationally certified and state licensed to provide healthcare as part of a healthcare team. APRNs' roles and skills are diverse, as we discussed. Our practice is, of course, within varied settings. APRNs bring added value to high-quality patient care. Additionally, the goal of the MS APRN is to maximize the care of MS patient in an ever-evolving healthcare environment, utilizing a collaborative team approach, which, as we have discussed today, results in expanding healthcare access, lowering healthcare costs, and ultimately improving the quality of healthcare provided. The MS APRN has specialized knowledge in varied roles, which serves to optimize patient care and treatment in MS. And of course, we must all work together to eliminate barriers to provide care to those living with MS, because quality and efficiency can only be attained when we are all working to the top of our scope. And with that, I'd like to thank you all for attending and for your attention. At this time, we will open the floor up to any questions you may have. Thank you.
Hi, this is Denise Bruin. We're actually going to do questions and answers at the end of the segment. We still have one more presenter. So if you could ask questions in the question and answer box after our next presenter, we will address those. So next up, I am honored to introduce Marie Namey, who was one of my first mentors when I came to MS Nursing. Marie is a nurse at the Cleveland Clinic, and she will be speaking to us on evidence-based practical guidelines.
Welcome to this session, Evidence-Based Practice Guidelines, part of the unique contributions of MS Nursing. I'm Marie Namey, an advanced practice nurse at the Mellon Center at the Cleveland Clinic. I'm also certified in multiple sclerosis nursing, and I am so happy to be involved in this presentation with all of you today. Over the years, our knowledge and understanding of MS has expanded. The care path for the MS patient has evolved, and the focus of care more than ever is evidence-based practice. So let's define evidence-based practice. So evidence-based practice is a conscientious, problem-solving approach to the clinical practice that incorporates the best evidence from well-designed studies, patient values and preferences, and a clinician's expertise in making a decision about patient care. This presentation will highlight published guidelines, the majority of which included direct contributions or endorsements by MS nurses. The idea behind the practice guidelines is to collate and evaluate scientific information, empirical evidence, and expert opinion. The goals of practice guidelines are to improve patient outcomes, provide optimal care for people with MS, reduce healthcare costs, enhance quality assurance, and of course, educate providers. Let's talk a little bit about the process and the development of guidelines. First, there needs to be the identification of need, and then certainly input from multidisciplinary stakeholders, and that could include individuals as well as organizations, people who have been involved in MS care in this particular case. Guidelines include an extensive review of literature. And of course, since we do not have all of the evidence that we need in the literature, expert opinion is ranked very highly also. But looking at the levels of evidence, we know that randomized controlled trials are certainly the gold standards. And in most cases, they are listed as a 1A level of evidence, systematic review of randomized controlled trials. But expert opinion is also a level of evidence ranked as a 5. And in between those, we see a variety of other levels of evidence, including case-controlled studies or case series, and also other types of controlled trials. The guideline topics in MS reflect the management of MS care in general, including symptom management, disease monitoring, and wellness. The symptom management guidelines that I will discuss include fatigue, urinary dysfunction, spasticity, and psychiatric disorders. The Paralyzed Veterans of America, the PVA, back in the day, sponsored the development of early evidence-based treatment guidelines. And these guidelines reflected the published research at that time, as well as expert opinion. There was a convening of a number of so-called experts in MS care, a convening of a group of multidisciplinary specialists who created these documents. And originally these documents were available to healthcare professionals, but then additionally these documents contained valuable information that people with MS could use for symptom management. These Paralyzed Veterans of America gathered together a council for clinical practice guidelines. And initially that included over 20 organizations that were very interested in the care of individuals with MS. Let's talk first about symptom management for fatigue. The Multiple Sclerosis Council for Clinical Practice Guidelines, working with the Paralyzed Veterans of America in 1998, published Fatigue and Multiple Sclerosis, Evidence-Based Management Strategies for Fatigue in MS. And an algorithm was created, and that algorithm is a little bit complicated to show here on a particular slide, so I'll walk you through it a little bit. This algorithm recognized the multi-dimensional nature of fatigue. We know that people with MS do report fatigue as a primary symptom. And this evaluation and management was designed as an iterative process with multiple loops within the algorithm, which recognize the uncertain dimensions associated with fatigue at any point in time, and then of course the need to reevaluate and adjust the recommendations over time. The algorithm recognized the importance of multidisciplinary management, but also recognized that resources available to patients will vary from one area to the next. The outcome measures recommended to assess treatment response was the Modified Fatigue Impact Scale, but thorough evaluation for alternative comorbid medical conditions as a cause of fatigue really needs to be undertaken before assuming that fatigue is related to MS. We know that medications that we prescribe for other symptoms in MS commonly contribute to fatigue, and they need to be adjusted whenever possible if the fatigue significantly interferes with quality of life. Primary and secondary sleep disorders also occur in MS, and they may contribute significantly to daytime fatigue. The next set of guidelines were introduced in 1999, and urinary dysfunction and multiple sclerosis was the title of that particular guideline. An updated elimination guideline was organized in and published in 2012 and is published in the International Journal of MS Care. And if any of you know me, you know this is a topic that is near and dear to my heart. The initial guideline spoke only of urinary dysfunction and recommended guidelines. The updated elimination guideline in 2012 highlighted both bladder dysfunction as well as bowel dysfunction in MS. And I'll share with you here the algorithm for bladder symptoms. This group of individuals that was convened included, again, a multidisciplinary panel, and of course included specialists in urology. Initially, we need to needed to evaluate treatable causes of incontinence using the DAPPERS model, which is an acronym actually for treatable causes of both fecal and urinary incontinence, which include delirium, urinary infection, atrophic urethritis and vaginitis, pharmaceuticals, psychological disorders, especially depression, excessive urine output, restricted mobility, and the S is for stool impaction. We first need to identify the symptoms that a patient is having and check for a post-void residual urine, and then move along the algorithm to determine what the treatment options would be. There's also an inclusion for pelvic floor muscle training, which can be very important for our patients. If patients have a large post-void residual urine, then possibly they may need to catheterize, as well as take an alpha blocker, and maybe utilize the skeletal muscle relaxant. If our initial interventions after our assessment have been unsuccessful with our patients, then certainly referral to a urologist is recommended, whether or not a patient has inability to empty or inability to store. The next section of elimination dysfunction refers to bowel symptoms, and that is divided into two parts of the algorithm: constipation with bowel incontinence and generalized bowel incontinence. It's important here in this particular algorithm to determine if a patient's mobile or immobile, as that can certainly affect their ability to have regular bowel habits. And then again, moving along through the algorithm, if our initial interventions have not been helpful for our patients, then referral to a GI specialist is certainly recommended. Particularly for patients who are immobile, they may indeed need a rectal exam, something that I'm certainly not comfortable doing in the office here, but certainly a gastroenterologist may be more comfortable in that particular part of the assessment. Utilizing the resources from physical therapy to help optimize mobility may also be an important intervention for some of our patients. And we can't forget just generalized recommendations: high fiber diet, perhaps using supplements, appropriate fluid intake, exercising, avoiding sugar alcohols, and behavior modification with a timed bowel regimen. The spasticity management and multiple sclerosis guideline was developed with help from the Paralyzed Veterans of America in 1998. And I do apologize that this particular algorithm is a little small, but again, the reference is there. We first need to determine if a patient has a new onset or a change in spasticity, and determine, are there concurrent factors present? Does the patient have another noxious stimulation? Do they have a bladder infection? Is there constipation? Is there something else that's causing the spasticity to increase? And then we need to treat that particular concurrent factor and then determine whether or not spasticity resolves. If there are other impairments or functional changes, then we need to move along on the algorithm and utilize medications as well as skilled rehabilitation strategies from our friends in physical therapy. If spasticity persists and continues to worsen, there may be a need for intrathecal baclofen, there may be a need for botulinum toxins or additional medications. Spasticity is one of those symptoms that needs to be continually evaluated, reevaluated, and the treatment algorithm may need to change over time. Another practice guideline, assessment and management of psychiatric disorders in individuals with multiple sclerosis, was first published in January of 2019 and then reaffirmed on July 16th in 2016 and again in 2019. This particular practice guideline was endorsed by the International Organization of MS Nurses. Basically, the information of this guideline included that people with MS are at high risk of developing emotional disorders. When undiagnosed and untreated, these disorders can worsen problems with functioning caused by MS. Emotional disorders can also limit the quality of life for people with MS. It can affect the quality of life for the families of people with MS. It can affect their work, relationships, and leisure time. Psychiatric disorders may also interfere with people's ability to be fully involved in their own care and effectively manage their MS. And unfortunately, as we all know, emotional disorders may lead to suicide. The guideline states that the most common mood disorders in MS are major depressive disorders, anxiety disorders, adjustment disorders, and bipolar disorders. In the general population, research indicates that emotional disorders are best treated with a combination of medication and psychotherapy. So the best intervention, as many of us know, is medication and talk therapy. So let's move along to guidelines for disease management, the use of disease-modifying therapy, and vaccine preventable infections and immunization in multiple sclerosis. The Academy of Neurology developed practice guidelines for disease-modifying therapies for adults with MS, the last time being in April of 2018. This is a very, very extensive review of disease-modifying therapies that were available up until that time. As we know, there have been additional therapies that have been made available for our patients since then. I think one of the best pieces of the guideline is that it strongly recommends early treatment in people with relapsing disease and more risk of spinal cord injury, even those with a single episode. This practice guideline really reflects the complexity of decision-making when considering initiating, switching, or even stopping disease-modifying therapy use for MS. The guideline panel really strove to reflect a patient-centric approach, incorporating assessment of attitudes, readiness to start or change therapy, therapy adherence, patient-specific factors like comorbidities, and an ongoing discussion of disease-modifying therapy use in people with MS. The panel reviewed the available FDA-approved disease-modifying therapies and medications that have even been used off-label. And the panel really engaged in transparency. Part of this panel and part of the publication included June Halper, the executive director of the Consortium of MS Centers, and IOMSN, again, nursing input. Looking at the practice guideline summary for vaccine preventable infections and immunization in MS, which was published in Neurology in September of 2019, the basic ideas here is that clinicians should recommend that patients with MS follow all local vaccine standards unless there are specific contraindications, and then weigh local vaccine preventable disease risks when counseling patients. We should recommend that patients with MS receive the influenza vaccine annually. We should also counsel patients with MS about infection risks associated with specific immunosuppressive and immunomodulatory medications and treatment-specific vaccination guidance according to prescribing information, and then vaccinate patients with MS as needed at least 4 to 6 weeks before initiating patients' immunosuppressive immunomodulatory therapy. Clinicians must screen for infections according to the PI before initiating ISIM medications and should treat patients who test positive for latent infections. In those high-risk populations, clinicians should screen for latent infections before starting immunosuppressive or immunomodulatory therapy, even when not specifically mentioned in the PI, and should consult specialists regarding treating patients who screen positive for latent infection. Clinicians should also recommend against using live attenuated vaccines in people who have MS, who are receiving immunosuppressive or immunomodulating therapies. Clinicians should delay vaccinating people with MS who are experiencing a relapse. I think we should all be on the alert for a recommendation when a vaccine is approved and recommended for COVID-19. So stay tuned for an update here. The use of MRI in monitoring for MS was set up as a guideline from the Consortium of MS Centers in 2018. And again, this guideline included an interdisciplinary panel of experts, including nursing. The ideas here is that a brain MRI with gadolinium is recommended for the diagnosis of MS. Spinal cord MRI is also recommended if the brain MRI is non-diagnostic or if the presenting symptoms are referable to the spinal cord. Follow-up brain MRI is recommended to demonstrate dissemination in time for diagnosis, to detect clinically silent disease activity when a person is on treatment, for safety monitoring, including PML surveillance while on treatment, to evaluate unexpected clinical worsening, to reassess the original diagnosis, or as a new baseline MRI before starting or modifying therapy. Every 6 months to 2 years, it is recommended that a person with MS have an updated multiple sclerosis, an updated MRI. A new part of the guideline was focused on gadolinium-based contrast agents because we have known that they do accumulate in the brain and to a much lesser degree with macrocyclic agents. While there is no known CNS toxicity, these agents should be used judiciously, recognizing that gadolinium continues to play an invaluable role in specific circumstances related to the diagnosis and follow-up of individuals with MS. And when we order an MRI, when we request an MRI, the clinical question being addressed should be included in the requisition for the MRI so the neuroradiologist can respond to our particular concerns. The American Academy of Neurology published a systematic review of the efficacy and safety of medical marijuana in selected neurological disorders in April of 2014, and then it was reaffirmed in January of 2020 to address certain questions about the use of cannabinoids to help with particularly symptom management in our patients with multiple sclerosis. I kind of included this under the part of wellness, if you will, when we're looking at guidelines for our particular patients. The following conclusions were made from this particular study. One question, do cannabinoids relieve spasticity in patients with multiple sclerosis? The review from this particular guideline indicated that oral cannabis extract, OCE, can be effective, and nabiximols and THC are probably effective for reducing patient-centered measures. It's possible that both OCE and THC are effective for reducing both patient-centered and objective measures of spasticity at 1 year. When we ask the question, or when the question was addressed, what is the efficacy of using cannabinoids to treat central pain or painful spasms in MS? The guidelines indicated that central pain or painful spasms, including spasticity-related pain, excluding neuropathic pain. Likely OCE is effective. THC and nabiximols are probably effective. Looking to see if cannabinoids help treat bladder dysfunction in MS. The panel indicated that there was moderate evidence that the nabiximols are probably effective for reducing the number of bladder voids per day at 10 weeks, but THC and OCE are probably ineffective for reducing bladder complaints. The question, do cannabinoids help treat tremor in MS, revealed from this particular guideline that THC and OCE are probably ineffective, but nabiximols are also possibly ineffective. So as you know, patients have a variety of ways that they can obtain cannabinoids. There has been no reference to indicate that smoked marijuana can be necessarily objectively helpful for our patients. But nabiximols, the mouth spray, and THC and OCE may be possibly effective for our particular patients. Let's take a moment too to look at the summary of evidence-based guidelines for complementary and alternative medicine in MS that was published in Neurology in 2014. These practice guidelines were endorsed by the Consortium of MS Centers and the International Organization of MS Nurses, and was reaffirmed most recently in January of this year. The guideline addresses the following questions in patients with MS. Do CAM therapies reduce specific symptoms and prevent relapses or disability? Can CAM use worsen MS or cause serious side effects? And can CAM use interfere with MS disease-modifying therapies? A sample of the findings from this extensive review indicated that ginkgo biloba is established as ineffective for improving cognitive function in MS. A low-fat diet with fish oil supplementation is probably ineffective for reducing MS-related relapse, disability, or MRI lesions, or for improving fatigue or quality of life. Reflexology is possibly effective for reducing MS-associated paresthesia over 11 weeks. And bee sting therapy is possibly ineffective for reducing MS-related relapses, disability, fatigue, total MRI lesion burden, new gadolinium-enhancing lesion volume, or health-related quality of life. And then if we look to our group across the pond who developed guidelines for the management of multiple sclerosis, primary and secondary care, which was updated in November of 2019. This is a multi-page document that reviews diagnosing MS, including optic neuritis and neuromyelitis optica, providing information and support, coordination of care, including exercise, vaccinations, pregnancy, and smoking. There's discussion of the many symptoms that patients have experienced. There's discussion about symptom management and rehabilitation, treatment of relapses, using steroids for acute relapses, how to recognize a relapse, and other medical therapy and social needs at time of relapse. Other treatments that were included were vitamin D and omega fatty acids. And this pretty much rounds out the guidelines that I was able to review that included the unique contributions of our nursing colleagues. The summary is that there are multiple practical guidelines that are available, but guidelines are useful tools only if implemented. Many MS organizations have been involved in developing guidelines. As the MS care path evolves, guidelines require updates and revision, and additional research is always needed for more evidence-based practice guidelines. Thank you so much for your attention.
Excellent. Well, that was a lot of excellent information. I learned a lot. We reached people all over the world. So next up is our questions and answers. We have about 15 minutes, so let's see how much we can get into here. Okay, so starting off, Amy. So when talking to patients about disease-modifying therapies, and now that we have all these different ways of delivering them, how are you discussing this in kind of a shared decision-making with patients? Has it changed in the past year or even month with how you're kind of narrowing down those options?
So that's a good question. Yes, in fact, it has changed. And these things are changing every single day, as we know. The challenges, I think, are related to where we're discussing it. We're doing mostly in-person visits, but we do have a small percentage of people that we're doing Zoom video visits with and whatnot. And, you know, I think one of the things that I do try to stress in my practice when I'm talking about disease-modifying therapies is mechanism of action. People, as you are well aware, and I know this is a worldwide concern, are scared. They're scared of COVID. They're scared of having MS in the times of COVID. They're scared of what they're doing to their immune system. So I really try to take a step back and talk a lot about what MS is doing in terms of their immune system. I also then talk to them about the different disease models. It's not an issue so much that I focus on convenience for people, but I talk to them and try to narrow it down. But you simply, you know, gone are the days when we had 3 options and we could just talk about all of them. Now we do try to focus and narrow it down. And when I'm looking at making treatment decisions, I talk about why I'm recommending perhaps this class of therapy or that type of therapy. And what I'm doing is talking about how those drugs work, but not only how the drugs work, just as importantly, what they don't do. And I talk about innate immunity and humoral immunity and immunity as it relates, to the best of my knowledge, to COVID. If they understand that the recommendations that I'm making are not going to necessarily put them at any greater risk in the long or short term, I think they're much more likely to be adherent. And they ask some very good questions when we get into some of the back and forth risk-benefit discussion that comes along with shared decision making. So my big approach these days, which has really changed, has changed for all of the disease-modifying therapies, and that is to talk about how the therapy affects their immune system, and equally importantly, what it does not do to their immune system.
Great point. Great point. Thank you. Okay, Stephanie. So we talked a little bit about some programs for advanced practice nurses in neurology specifically, but any ideas on how to get more knowledge to nurses about neurology and specifically MS? And then also, where do physician's assistants fit into that algorithm?
So that's a great question, Denise. You know, I know that the consortium, the CMSC, actually offers a voluntary certification for those providers and professionals that are working in MS specifically, because it is such a specialized area. And so I know that they actually offer a test that PAs can take, therapists can take, nurses can take, and of course, APRNs as well. And so that certification really just, it serves to show the individual to show that they have this advanced knowledge. So how do you actually get the advanced knowledge? Well, there's certainly lots of information online through the International Organization of MS Nurses website. There are regional programs that can be attended. Those are generally more focused towards nurses and advanced practice. But I think that would be something that others would be able to join into as well to kind of increase their knowledge base. In addition to that, of course, attending programs like this is certainly another good way to be able to increase knowledge. And then reaching out and finding a mentor. I know specifically with nurses that the IOMSN does have a program that's available where they can pair a new nurse in MS or a new APRN in MS with someone who has been there, done that, and can share their knowledge and assist them. As far as PAs go in that kind of a program, I know that my colleague Brian Walker has worked on educational programs and ways for them as well to mentor new PAs. And so I'm not certain what the name of that particular program is, but I know that that's something where he's at Duke that they've really worked on to try to increase knowledge and spread the information and assist those who are living with MS.
Thank you. Okay, and then Marie, most nurses in the MS arena know that kind of bladder and bowel is your expertise. So if someone wanted to read more about this or wanted to try and implement some of this in their own clinic, where would they look for these resources that you posted?
So there are multiple resources available, including the one that was listed, or actually the two that are listed in my presentation. One can go to the mscare.org, the Consortium of MS Centers website, and find some of the education tools. And there will be the entire bit of information. If you look back at some of the issues of the International Journal of MS Care, in a supplement, there was a multi-page article including the algorithms for both bowel and bladder care in MS. I would like to add, however, as I was thinking about this presentation, that we do need some additional guidelines. I think that would be helpful. And considering that same area of the body, I'd suggest that there be some interested people who get together to look at a guideline for sexual function in individuals with multiple sclerosis. I think that would be a nice supplement to the bowel and bladder piece.
Agreed. Okay, and then this is a question for kind of everybody on the panel. Tricia, you as well. So with COVID and with a lot of our appointments going virtual, how has this changed some of your MS nursing practice? Any new ideas that have come out of this, or resources that you've kind of found that you didn't realize before? Just kind of your comments on MS nursing during the pandemic.
Okay,
I'll go ahead and start.
I'll go first, and so.
Go ahead, Trish.
So we have used several different platforms, not only our EMR, but our EMR has been the most problematic. So we've used more platforms like Skype and FaceTime, things that are very usable for patients. And I have found that patients are very willing to let you come into their home and share, and they actually are enjoying having us be able to see them in their homes. What I think is lacking is sometimes the ability for them to conceive making a change. So I think that our lack of being able to get timely MRIs and things of that nature, we're doing very good symptom management, but I think that some of our changing of therapies lags a little bit behind our symptom management. But it's been very good to talk to persons and be able to reassure them during this time.
Amy, do you want to comment?
So, yeah, thank you, Denise. I talked quite a bit about the concept of COVID and the immune system and people's misunderstanding about that, and the understanding to the best of our ability. I think one of the things that we need to continue to stress is the importance of the annual flu shot for our patients, and I'm encouraging our patients to get them as soon as possible. I think our patients are also much more tech savvy or web savvy, perhaps, than they ever wanted to be. I know I'm more savvy than I ever thought I would be, but and still know where I need to be. But I encourage our patients to go to various different websites to take a look at things with respect to their disease-modifying therapies. I send them to the website for the Multiple Sclerosis Association of America, for the National MS Society, for the Multiple Sclerosis Foundation. I would imagine that our colleagues in Europe would be sending people to the website for the EMSP, European Multiple Sclerosis Platform, as well as the MS Trust and the UK MS Nurses. For those of us in clinical practice, two websites that are excellent resources always is the IOMSN website, iomsn.org, and the website for the consortium, which is mscare.org. These are full of incredible, valuable references for our patients and for the healthcare providers who may be finding that they're caring for the patients in the days of COVID because the patients can't or don't want to be able to travel all the way to an MS center. So offering those opportunities to private practices or small neurology practices that may have never used them before, I think that's one of the things that's a real big advantage.
That's very true. One thing I wanted to point out is that the IOMSN regional meetings, we're going to be doing them virtually in the next couple of months too. So for nurses or other MS care providers out there that are interested, keep your eye out for that, because that's another way to get more information like what we presented today. And since it's going to be virtual, hopefully we'll be able to reach a lot more people than we have previously. So we have about 1 more minute. I don't know, Steph or Marie, did you have anything else you wanted to add today?
We were able to transition pretty quickly to virtual visits with our patients, as we had that platform in the past. And I think patients felt very more comfortable knowing that we are continuing to provide care for them during this time. They knew they had that safety net with us. And I think it made them then more comfortable to return to the office, as they have started to do the last month or two, because they realize that we're there for them and that we'll continue to provide care on however they're comfortable in receiving care.
Thanks. Well, I think we're out of time. Thank you, everybody. This was excellent. Excellent, excellent. And I hope to see everybody in person soon.